Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to be looking at the newborn blood spot. Right, so this morning we're going to look at newborn blood spot, which comes under the umbrella of newborn screening. Hearing and NIPE also sit under that umbrella, but we'll look at those in a different session. So essentially, a newborn blood spot is a screening test. Remember, it's not diagnostic, it's a screening test, but it aims to pick up 9 potentially life-threatening conditions. And if we can pick that up nice and early, we can get early referral and early treatment. And some of these conditions really require treatment as early as 3 weeks. So it is important that we do flag these up sooner rather than later. It's done ideally on day 5, counting the birthday as day 0. It's a simple blood test by means of pricking the baby's heel and gathering some blood on a special card. And we need to, if we've got babies that are in special care or preterm babies, there are some other special considerations we need to take into account, and we'll talk about those as we go through. So the first thing, or one of the first things it's looking for, is sickle cell disease. And about 1 in 2,800 babies will be affected by sickle cell disease, and sickle cell disease really affects the quality of the hemoglobin. So red blood cells, normally we've got those lovely nice round red blood cells. When they're deoxygenated, they change shape and become rigid, and they become sickle shaped, so a little bit like a crescent moon shape, and they can then block small blood vessels and reduce blood supply to that area, and that then causes what we call a sickle cell crisis. It's extremely painful for people, and it can be very severe and last up to about a week. It's an autosomal recessive condition, so that means there's 2 faulty copies of the hemoglobin gene, so there's 1 from each parent. And there's lots of different forms of sickle cell disease, but the most common is sickle cell anemia. The effects on how it presents will be varied, but you may get delayed growth, there may be lung issues, and there is a query over whether or not there may be cardiovascular accidents, so little strokes. Treatment will be, hydration, warmth, medications, encouraging parents to have their babies vaccinated, and antibiotics to reduce infection risks. So cystic fibrosis is a disorder where the chloride transport across the cell membranes is affected. So the people with cystic fibrosis get a build-up of thick secretions in the various organs that are affected. And it's primarily sort of lung, pancreas, gut that gets affected. 1 in 2,500 babies, so you may well come across this in your career. Certainly as a community midwife, I had 1 baby that was this was picked up on newborn blood spot. Again, autosomal recessive, and most cystic fibrosis sufferers do have severe symptoms. These can be breathing issues, lung infections, and obviously if you've got repeated lung infections, essentially that's going to damage the lungs. And because the thick secretions are in the pancreas, that actually stops the enzymes needed for digestion getting to the gut. So if we don't treat this baby, babies are likely to present with failure to thrive, breathing issues, and digestive system issues. And if you remember, we said the pancreas gets blocked, so the enzymes can't get to the gut. So enzyme supplements, high energy diets to help with the weight gain, physio appointments, and frequent physio and antibiotics to reduce the risks of infections. Treatments for cystic fibrosis has come on massively over the years, and whereas historically they had quite a poor life expectancy, now actually quality of life and life expectancy really can be quite good for cystic fibrosis sufferers. And certainly I've got a colleague who currently is off on maternity leave. So, yeah, you know, they can lead perfectly normal lives. Congenital hypothyroidism is where there's not enough thyroxine being produced, and we need thyroxine for normal growth. Again, about 1 in 2,000 babies, so you are quite likely to come across some of these within your career. If we don't treat it because we need it for normal growth, these babies again are likely to present with failure to thrive, so poor growth, learning difficulties. If we have preterm babies, so they're less than 32 weeks, they have low levels of thyroxine preterm anyway. So we need to repeat the newborn blood spot at either discharge from the neonatal unit or 28 days old, depending which is the soonest. And there are no symptoms for us to see at birth, so there's nothing that would flag up for us. Although obviously, if the mother has any sort of thyroid conditions, then certainly that would perhaps flag up that there's a possibility. And treatment would be with thyroxine. Now we move on to the 6 inherited metabolic diseases. So this means that these are all autosomal recessive, so there's a faulty gene from each parent, and all of them mean that the baby can't produce the specific enzymes needed to metabolize either fats or proteins usually, and some of them can be fatal. So the most common one that we know, and certainly when newborn blood spot was first introduced many years ago, this was pretty much the only thing it looked for, was something called phenylketonuria. And these babies can't use up, they can't metabolize protein. So they get a buildup of a substance called phenylalanine, and if we don't treat it, then it will cause brain damage. There's no symptoms for us to see at birth, so it really is about picking it up on this blood spot, and really the quicker we can get treatment, and this is one of the ones that ideally wants to start treatment certainly by about 21 days. MCAD. Now, this is multi-chain, and I can't remember the rest of the word, but you really, essentially, this one is they can't metabolize fats very well. They can't turn those fats into energy. Really, they're poor feeders and often prone to infection, and stressful events can cause a metabolic crisis. So if you've got, you really don't want with these babies to have long periods of not eating. And certainly there was a case when I was training many years ago, before there was much known about MCAD. We were told about a case of a little old lady who had gone in for surgery, and obviously she had been starved overnight, and nobody knew. She didn't know she had this disorder, and she'd obviously just managed it through her whole life by eating regularly, but because she was starved overnight, it actually caused huge problems for her, and sadly she didn't survive. So if we need to avoid those long periods without food, so if there is babies with MCAD highlighted, then they really do need to be fed regularly. Any sort of infections, it might present with vomiting, raised respirates, seizures, sweating, excessive tiredness. So these babies seem to be very sleepy, they don't feed very well. And obviously it's an emergency, so they need high sugary drinks if they're older, and maybe IVs if they're still very babies, and hospitalization. Maple syrup urine disease, again, this is where they can't metabolize these amino acids. They are very rare, as you can see. Again, tend to present with poor feeding, vomiting, excessive sleepiness. For these ones, symptoms do often appear before their day 5. So these ones we are likely to pick up that we may not know what it is, but we'll know that something's not quite right with this baby. And if we don't treat it, again, brain damage or death could be the outcome. And for these babies, even minor illnesses can lead to serious problems. Treatment exactly the same as with MCAD. Isovaleric aciduria, again, another amino acid protein metabolism issue. Again, very rare, very similar symptoms to the others. But there's a lot of babies that will have mild IVA that will have no symptoms while they're well, and they'll only, if they get unwell, they will produce symptoms then. And again, similarly, if we don't treat it, brain damage and death could be an outcome. And treat, some babies don't become unwell for months or even years. Low protein diets and the emergency regimes as per the other disorders. Then glutaric aciduria 1, again, another amino acid metabolizing issue. Again, very, very rare. Again, very similar signs and symptoms to the others. If we don't give treatment, brain damage will affect muscle movement, which eventually will lead to a coma, and the treatment is the same as for the other disorders. Homocystinuria Pyridoxine unresponsive. Again, very rare. No symptoms at birth. Babies tend to be quite well in early life, but later symptoms, they can have vision symptoms, learning difficulties, osteoporosis, joint and bone problems, blood clots and strokes. So you can see that because there is no symptoms at birth, and actually they may be well for many years, it's important that this is picked up on the blood spot, because we could have already had problems developing before we're aware that this person has this disorder. So our responsibility with screening tests. So in the 3rd trimester, we need to make sure that they have a copy of the screening tests for you and your baby booklet, which is available to all pregnant women. And what you usually find is that women have looked at the screening for them antenatally in that booklet, but they haven't actually looked at the back for the baby screening. So, signpost them back to that booklet to have a read of the screening tests for the baby. And then arrange to discuss and check their understanding of those tests. Now, they can accept or decline all of them, or they can accept some of them and not some of them, but the 6 metabolic ones, so the PKU and the MCAD and all of those, they come as a group. So you can't say I'll have PKU, but I don't want to have the rest. They come as an actual clump of tests. So they can say I'll have sickle cell and the hypothroidism, but I don't want the rest. That's fine. But they can't say I'll have PKU, but not the rest, because they can't separate those metabolic ones. So at least 24 hours before you're going to do the test, we need to make sure that she's got a copy of that screening test booklet. And particularly if English is not their first language, really you need to have ensured that you have gone through this either with an interpreting service, or that you have got a copy of the information you want in a language that they can understand. So you're checking that they understand what they are agreeing to, and that they're agreeing to not only the testing, but the storage of the cards for quality assurance. You can't, if they agree to the test, they can't opt out of storing the cards, and the cards are stored. Apologies for spelling there. I must have been having a moment when I was typing. The cards are stored really for ongoing QA. So they check results, they monitor, they improve processes. However, if later on someone was wanting to do research, then the parents would need to be contacted to give consent for the blood on their cards to be used in either clinical or research trials. So we get verbal agreement for the test. And when we're thinking about our preterm babies or any baby that is admitted to the neonatal unit or your special care unit, they will have a newborn blood spot done on admission to the unit. And this is specifically because of sickle cell disease. If that baby needs to have a blood transfusion, then by day 5, the blood that is in that baby is not the original blood, if that makes sense. So we need a comparison sample so that both cards will go to the lab, but the card that's been taken on admission will be marked pre-transfusion. And then day 5, the test will be done as normal, or day 28, or discharge from the unit if they are less than 32 weeks, if that makes sense. So the test itself, you need to check the card, you check you have your right equipment. So on the card, you need to make sure that it's in date because they do have expiry dates on them. They are like they're pre-printed cards that are like blotting paper. And there is, I will put a link underneath to the electronic library for health. And if you are a healthcare student, certainly you should be able to access this site, and I would say definitely undertake the module on newborn blood spot because it will take you through all of this and all the process for doing it. So yes, check the cards in date, check that you have filled in the baby's NHS number. This is a mandatory element, and if you don't, the card will be rejected and the test will have to be done again. And we've already said that some of these treatments need to take place by day 21. So if you are having to repeat a test, potentially you are delaying treatment on an affected baby. So it is important that we get this right first time. Make sure you've got your personal protective equipment, so gloves, pinny. Clean the baby's heel. Don't use alcohol wipes, just plain water is fine. Allow it to dry. Make sure you use a approved lancet. So a lot of places use tenderfoot, which is like a little square blood spot lancet. So the depth is calibrated so it doesn't go too deep into the baby's foot. So please don't use just any old needle or ones that are meant for adults. Use a specific device that is meant for neonates. Okay, wait for the blood to flow. It will flow quite nicely if you wait for it, and also you have a bit of gravity. Now, some people will have the baby, particularly if the mum's breastfeeding, get the mum to feed the baby, and they'll do the test then. It's whatever the parents are comfortable with. You don't need to squeeze. Please don't squeeze as well. It will come. And you need one spot to soak through. There are pre-printed circles on the card, and you need to allow the spot to drop onto the card. Don't put the card onto the baby's heel. So allow that spot to touch the card and soak in, and you want one spot to soak right through that card. So if you wait for a nice big spot, it will do that. You cannot layer spot upon spot upon spot, and you can't put lots of little spots onto the card because these will be rejected by the lab. And in an ideal world, they need to be posted the same day or go by courier to the lab. So different trusts will have different processes for this. If you're in the community, they may well gather them all up at the end of the day. They go, the test itself, the cards itself come in what's called a glycine envelope. So it's a bit like a greaseproof paper bag. It's like a waterproof bag. You need to make sure that you keep your blood spots out of that bag until they have dried. So let them dry before you actually put them in. So I usually used to have the blood spot bit sitting slightly proud of the envelope. Many trusts will also have some form of book or computerized system where it can be documented that the test has been taken and that it has been sent. Okay, so the results usually go back to the health visitor by 6 weeks, and they will put them in the red book, the child health book. If there's a positive result, then obviously the parents will be contacted much sooner, and they will be offered further tests and diagnostic tests and treatment. And it is, as I say, important that we make sure that we have documented that you have discussed the test, that they understand what they're accepting, that you've undertaken the test, and that the test has been sent to the lab. It's poor practice to kind of hold on to them in your bag if you're a community midwife till you go back to the unit the next day, because what happens if you are unwell? You're delaying those samples getting to the labs for processing. And there you have it, newborn blood spot. I hope that's been useful. I hope it's given you some insight into what the test is about and how you can explain it to parents. If you haven't already subscribed to the channel, please do, and also look for us on Facebook at The Motivational Midwife. And I look forward to seeing you next time.